All right, let's get right into it. If you're an MBBS student staring down the barrel of your UHS final year surgery exam, you are in exactly the right place. We're doing a high-yield system speed run explainer today. We are totally bypassing the heavy textbooks to focus strictly on the core concepts that your examiners absolutely love to test.
Here's our roadmap. We are going to blitz through 5 key areas: neck and breast essentials, upper GI and stomach, lower GI and hepatobiliary, hernias and abdominal wall, and finally, surgical trauma and shock. Let's go.
Starting with Section 1, Neck and Breast Essentials. We're hitting the high-yield differentials in those absolute must-know protocols.
When someone presents with a breast lump, age and presentation are literally your best friends. Think about it. A 20-year-old with a highly mobile lump, that classic breast mouse, is a fibroadenoma, no doubt. But shift the demographic. Say a 45-year-old with bloody nipple discharge, you're looking at a duct papilloma. And if that lump is massive and growing rapidly in a 35-year-old, boom, phallus tumor.
Now, for any suspicious breast lump, the triple assessment is completely non-negotiable. You cannot skip steps here, guys. First up, clinical evaluation. Then, radiological assessment, like an ultrasound or mammogram depending on the patient's age. And finally, cytology, so an FNAC or a core biopsy. This exact sequence is absolute law, both on the wards and on your exams.
All right, Section 2, upper GI and stomach. This is where knowing the subtle physiological differences will literally score you massive points.
Differentiating peptic ulcer disease really boils down to 2 things: timing and acid. Duodenal ulcers, they are swimming in a hyperacidic environment. The pain is famously relieved by eating, but then it comes roaring back 2 to 3 hours later when the stomach empties. Gastric ulcers, which usually hang out in the antrum, hurt immediately after eating, which is why these patients often lose weight. Oh, and absolutely do not forget, gastric ulcers carry a malignant potential. Duodenal ulcers almost never do.
You know, examiners love their surgical triads. These are your instant diagnostic cheat codes. Picture this. A patient is violently retching, they've got severe retrosternal chest pain, and you actually feel that crackling surgical emphysema under their skin. That is Mackler's triad for a ruptured esophagus, also known as Boerhaave syndrome. On the flip side, if they're in pain, they're retching but nothing is coming up, and you literally cannot pass a nasogastric tube, that is Borchart's triad, a dead giveaway for a gastric volvulus. So once you've actually identified an ulcer, eradicating H. pylori is the next big hurdle. The trick here is all about the timeline, and examiners will definitely try to trip you up on this. You absolutely must stop PPIs 2 weeks prior and antibiotics 4 weeks prior to testing. Otherwise, false negatives. Once confirmed, you hit it with a strict 14-day course of triple or quadruple therapy. Moving on to Section 3, lower GI and hepatobiliary. Stay sharp here, because these concepts are tested heavily.
Contrasting inflammatory bowel diseases is all about where it is and what it looks like. Crohn's disease, think those classic cobblestone skip lesions. It usually hits the terminal ileum, but remember it can pop up anywhere from the mouth to the anus. Ulcerative colitis, though, almost always starts down in the rectum and creeps continuously upward, turning the colon into this featureless lead pipe with pseudopolyps.
It's 3 a.m. on a busy night shift. These triads are your absolute best friends for quick triage. Murphy's triad, that gives you the classic acute appendicitis picture: pain, vomiting, and fever. If you've got intermittent pain, fever, and jaundice, you can lock in Charcot's triad for cholangitis. And for hemobilia, which is bleeding into the biliary tree, you're looking for Kincke's triad: pain, jaundice, and melena.
Surgeons love naming things after themselves, right? But fighting these eponymous nodes is usually very bad news. We're talking advanced metastasis. An enlarged left supraclavicular node, that's Virchow's node, pointing straight to gastric cancer. A palpable nodule right at the umbilicus is a Sister Mary Joseph node. And if an exam prompt mentions drop metastases to the ovaries, they are practically handing you the diagnosis of a Krukenberg tumor on a silver platter.
Section 4, hernias and abdominal wall. This is pure surgical anatomy, and it's an absolute must-know.
Please, never mix these two up again. The defining key is their spatial relationship to the inferior epigastric vessels. Direct hernias punch straight through a weakness in the abdominal wall, specifically Hesselbach's triangle, which is medial to those inferior epigastric vessels. Indirect hernias, however, take the scenic route. They enter the deep inguinal ring, lateral to those exact same vessels.
When we're talking femoral hernias, your surgical strategy totally depends on how bad the situation is. The Lockwood approach is a low incision, great for simple cases. Low Thescend is standard. But the absolute high-yield takeaway here is the McVitie high approach. Why? Because if the bowel is obstructed or strangulated, going high up above the inguinal ligament gives you that crucial access you need to safely resect the dead tissue.
Finally, Section 5, Surgical Trauma and Shock. This is where fast thinking saves lives and gets you high marks.
Let's do a quick rapid-fire check. When a trauma patient rolls into the ER, what organs are you immediately suspecting are damaged based solely on the mechanism of injury? Take a second to lock your answer in.
Okay, the statistics dictate your first move. The spleen takes the absolute brunt of blunt trauma, but the liver, that is the primary casualty in penetrating injuries. Whether it's a steering wheel to the gut or a stab wound, knowing these probabilities instantly guides your initial assessment.
This fast scan algorithm needs to be burned into your brain. A patient's hemodynamic stability completely dictates what you do next. If they have a positive fast scan and they are crashing, meaning hemodynamically unstable, you do not wait for imaging, period. They go straight to the OR for an exploratory laparotomy. If they are stable, well, then you actually have the time to get a contrast-enhanced CT of the abdomen to map out the exact injuries.
You have to actively fight the lethal triad of trauma. It's a vicious cycle. Hypothermia halts the clotting cascade, which leads to coagulopathy. That coagulopathy causes massive bleeding and poor perfusion, resulting in metabolic acidosis, which just makes the other two even worse. Damage control surgery isn't about doing a definitive, pretty repair right then and there. It's about stopping the bleeding, packing the wounds, and getting them to the ICU to break that lethal triad first.
All right, that wraps up this surgical speedrun explainer. You've got the high-yield blueprint for your UHS finals now. But as you transition from student to surgeon, ask yourself this. When a crashing trauma patient rolls through the doors at 3 a.m. and your textbooks are miles away, will you be ready to trust your training and break that lethal triad? Best of luck on your exams, and I'll catch you in the next explainer.